Well, we've had a bowel cancer working group in place since 2013, and one of our goals has been to try and identify the quality of treatment for bowel cancer across New Zealand. So we've been working on this for quite a long time, and none of the other tumour streams have got such a similar group. This group is multidisciplinary. There's patients, multiple clinicians, and the ministry all involved.
So the work of the National Bowel Cancer Working Group has been quite groundbreaking, and it's provided a lot of insight into how we can gather information in New Zealand. This report is giving us information about the quality of bowel cancer care provided throughout New Zealand, and it's showing us some quite considerable variation both throughout the country and variation within ethnic groups in New Zealand. We have to think, both as clinicians, as organisations and as the public, whether we think that that's fair and reasonable, and if it's not, then we're going to have to look at ways to provide quality improvement in those organisations that's going to benefit the patients and reduce that variation.
Well, the quality indicators are a way of comparing DHBs, but they have to be looked at with the understanding that there are some differences across the country. For instance, some centres have particularly complex cases sent to them, and so the actual population may be slightly different. The differences we're finding, though, are in some cases wider than we'd expect even with that reality.
So the data is important, it's necessary, but it's not sufficient. There needs to be that engagement to get the changes that you need in clinical practice decisions.
The best thing is for the DHBs to engage with the reason why their indicator might not be as good as elsewhere, perhaps having some help from other DHBs that are doing better, and then putting an action plan in place to deal with that.
Organisations need to understand their own data, because there might be considerable differences between patient populations in Auckland versus Tairāwhiti. And so those organisations have to understand their own data. And then we need to look at ways that we're going to provide quality improvement in places whose outcomes aren't looking so good, whether that be local investments in quality improvement programs within those DHBs, or whether it's actually buddying up similar sized DHBs, so not just saying that only big places do great work, but perhaps there's smaller DHBs whose outcomes look great. What are those places doing? And link them up with organisations that need to provide some improvement. I think that the main thing is that this information has to be viewed in the light of quality improvement. It's absolutely not about punishing DHBs or clinicians whose data might not look that great. It's actually about improving things for patients.
With an understanding about the quality of treatment across the country, we can ensure that there is an improvement in quality at all sites, so that wherever a patient is diagnosed, they can be happy they will end up with good treatment.
And the next step really is to roll that out and use the Bowel Cancer Working Group as a model for the other large volume tumour streams. So we want to look at tumour streams where there's a lot of patients experiencing that cancer, but also tumour streams where there's a big equity gap. So the next tumour stream that indicated work is progressing is prostate cancer. There's significant work going on in the lung cancer space as well.
It takes a lot of effort, it takes a lot of patience, and there are some bumps and stumbles along the way, but persistence produces results. And it took us a number of years, but we're definitely now seeing the full value of having good, meaningful, compelling information on quality and outcomes in Canada.